Everyone. Welcome you all to our weekly webinar session. Today's session is breast cancer surgery, all the question of oncologist. This is the session 2. And we will have 3 faculties today. Dr. John Conybeard from UK. He is a clinical oncologist from Burt's NHS Trust UK Hospital. We are having Dr. Mohammad Zakirullah, who is a consultant surgeon, Whip Cross University Hospital, NHS Trust UK, and Dr. S.K. Farid Ahmed, having a 2 identity, one in Wickham Hospital consultant, and also working as a consultant in BRB Hospital and Levitt Cancer Hospital in Bangladesh. So last week, we couldn't complete our session due to the overwhelming response from the participants, so we decided to continue it. Today, the anchor will be Dr. Shumon, but in between, as he's taking some time, I'm going to start it. So I want to request our President, Professor M.A. Hai, sir, to formally start the session, then we go to our session directly. Sir.
Thank you, Dr. Kamal. Bismillahirrahmanirrahim. For my heartfelt welcome to all of you. Assalamu alaikum, everybody, all the participants. Dr. and Dr. Reed taking their pains and being us in our effort. Without any delay, I request you to start immediately. Over to you, Dr. Kamal.
So thank you, sir. We had some discussion and the random questions were there. So the topics that we want to discuss is surgery after neoadjuvant chemotherapy. So now it's the era that where there is an indication, we are going to use total neoadjuvant chemotherapy with a target of achieving PET-CR, but we are not always achieving PET-CR. Sometimes we are achieving PET-CR, sometimes we are not getting a PET-CR. Sometimes we are getting PET-CR in the tumor, but not in the node. So all these areas, we are having some issues. So the question is, if there is a complete radiological regression, how we need to assess the response and how much you are going to do the surgery? Zakir Bhai.
First of all, whenever we actually try to do some sort of neoadjuvant chemotherapy, especially in the United Kingdom, we always assess them by MRI scan of the breast. So for example, somebody has got, say, 3 centimeter cancer or 4 centimeter cancer. We would like to put a marker clip beforehand, and then, of course, they will go for neoadjuvant chemotherapy. So pre-chemotherapy MRI scan, halfway through the chemotherapy, another MRI scan, just to see the response, whether this chemotherapy is the effective one, or they need to change the chemotherapy, or they need to add anything else. And that's the time they can reassess the whole thing. If there is good response or better response, then of course they continue this chemotherapy with all other monoclonal antibodies or targeted therapies, whatever is necessary. So once the chemotherapy is completely finished with the targeted therapies and immunotherapies, then at the end of the treatment, we do another MRI scan. So in that particular time, if we find that there's nothing you can see, only the marker clip is there. So that is how we actually assess the complete radiological response, they would say. Okay, so once we know the complete radiological response, you don't need to do any more scanning. Sometimes some people can actually compare with the mammogram, sometimes with ultrasound, but there's no need. Similar thing can be assessed in the axilla as well, because sometimes some patient has got before chemotherapy 1 or 2 lymph nodes positive. We normally mark them as well. To the same thing called targeted axillary dissection. So exactly same thing is assessed by the MRI scan and also ultrasound scan, because it will cover the axilla and find out whether the lymph nodes are completely gone as well. So this is the assessment by radiology. And then of course in the surgery, when you take the area out or the clip out, then it will be assessed by pathological assessment to see complete pathological response.
So you see there is a radiological response. Just as a non-surgeon, we need to know that when there is a marker clip, how much you take out around the marker clip to confirm that you have taken out the tumor.
Okay, so again, the same question. If radiologists are saying that this is complete response, complete radiological response, then you just need to go and take the clip out, maybe a centimeter, maybe half a centimeter, or whatever it is surrounding that clip, just to add a little bit of tissue. You don't have to take the original size, which was the 3 centimeter or 4 centimeter. No, you don't have to. Just take the marker clip out along with some tissue surrounding area.
So shall I understand that your center standard is you are always doing the assessment of neoadjuvant by MRI?
Yes. Yes.
Yeah, sorry.
No, you're right, Kamal. Sorry to interrupt you. Yes, if you really want to assess properly a response from the chemotherapy, I think MRI scan is the most sensitive thing to use. Of course, some centers don't have MRI. They use mammogram, but sometimes it might give you a false result. That's the only problem, because a mammogram itself is only 70 to 80% sensitive. It's not 100% sensitive. MRI also not 100% sensitive, but it can give some false result. But if you're targeting something, and from the very start and at very end, then it is much easier to use MRI and find out.
Any comment here?
Thank you, Kamal. Jakurlabhai has given the full background and some answered most of it. I would also agree that there is no need to do complete excision of the original tumor bed. We just do a wire-guided wide local or a radio frequency seed-guided wide local excision. And if a place we have frozen section facilities available, we'd like to see the frozen section margins. We need at least 1 millimeter clear margin to be able to say it's completely excised. And that should be more than enough. So this debate has been ongoing worldwide about how much to take out post neoadjuvant chemotherapy with good response. And as Jakirbhai said, that is the standard practice, that we do not have to excise it all. And if there is no frozen section available, then obviously we would have to do a wider excision, and we have to counsel patient that if the margins are positive, she may require a further margin excision. This is what is standard practice in UK. But from Bangladeshi perspective, it could be a little bit of challenge. But that does not mean that we would counsel patient to do a mastectomy, because it has got a significant negative impact on psychological and physical well-being of the patient. And also, let's just not forget the trial that was done in Sweden about nearly 50,000 cancer patients, where it is evidenced that breast conserving surgery patients with cancer survive longer than mastectomy patients. So we need to have a rational discussion about it with the patient, whether if there is no frozen section facility available, whether they'll be prepared to go for a second operation for margin. So as I said, this is also current practice in UK anyway. As long as patient understands and accepts that risk of a second operation, in the absence of a frozen section facilities, I'm happy with it. Thanks very much.
I see Professor Salma is with us, who is practicing breast conservation in Bangladesh perspective. Salma, would you like to make any comment on doing the assessment? What do you practice? Do you using MRI as a assessment, or you are doing the ultrasonogram or mammogram, and how much margin normally you practice when there is a marker clip and radiologically said that is a total radiological response? Salma, Professor Salma.
Thank you. Kamal bhai, thank you. Actually, we are practicing for very short period of time, and our experience is very small actually. But we are getting patients with complete radiological response. Only the marker is seen there. So in those cases, we are, in all the cases, we are doing actually the frozen section biopsy, localizing the marker with the wire, and excising the marker with surrounding at least 1 centimeter of the margins. And of course, we wait for the frozen section biopsy, frozen section report on the margin clearance. That is our usual practice. Actually, without frozen section, we are not doing that.
Great. So, Salma,
In some cases, actually, I also want to add this. In some cases where we have to do the surgery in Dhaka Medical College Hospital, where the frozen section facility is not available, and during the COVID situation, we actually are dependent on the frozen section biopsy for DSMMU. But during the COVID era, the frozen section, after COVID also, frozen section was, they were not allowing frozen section from outside. In those cases, we took a little more margin. We waited for the paraffin section, and with proper counseling with the patient, that the patient may need another surgery or second loop surgery for clearance of margin. Some cases we have done it also. Thank you. Kamal bhai?
So thank you, Salma, for sharing your experiences. So we are happy that we are, in Bangladesh perspective, even in Dhaka Medical College, we are practicing neoadjuvant followed by breast conservation. We are doing with frozen. When there is no frozen, we are going to optimize the situation by taking wider margins. So whatever we hearing from Zakir Bhai, Farid, and we say hear the same echo from Salma. That is a great news. So next question to Salma, in your perspective, that after normally we select to be on safe, that early stage breast cancer, but after neoadjuvant, it was a big tumor, but there is a good response when you go for breast conservation. Do you face any challenge from the patient's perspective or colleagues that, well, it was a big tumor, it has gone down, survival could be a challenge? Are you facing a challenge like that, Salma, in the discussion?
No, actually, in all the cases, we are doing the MDT meeting, and the decision is made in the very first, that before starting any treatment, we all sit together and decide and chalk out the plan. And when according to the decision, when the neoadjuvant is completed, either the total or partial, then again we reassess the patients. So when there is a complete response, there is no controversy, and on the side of the patient there is also no controversy, and we are doing the conservation. But in some cases there is partial response or no response at all. In some cases, in those cases, we actually assess the patient again in the tumor board, reassess the situation, talk to the patient and the family. In some cases where there is no response, it's a big tumor, then in that case, we again reevaluate and talk to the patient and do accordingly. We get consensus. In some cases, there is partial response, or apparently clinically there is response, but on MRI, there is the tumor is, it's not actually smaller, uniformly small. There is patchy response. In those cases, actually, we do face a challenge, and we need to talk to the patient and the colleagues also. And a decision is made according to the consensus. But it's not a great challenge.
Thank you, Salma. So in our last week discussion, Dr. Zakir Bhai brought up the issue of the Swedish trial, where we know that the huge big data in favor of breast conservation, but it was on early breast cancer. And he was confident, he was telling that the message should be very clear, that no, today in 2021, breast conservation is not a question of survival in early breast cancer. It is giving a better survival. Dr. Zakir Bhai was bringing the issue last week, I remember. So I brought this paper. It is an interesting paper published in October 2021. And this is the MSKCC group, 650 patients. And interesting is the tumor size is T1 to T3 with N1. So patients were not eligible for breast conservation. They have picked up those, given NSCT, and then they have done the breast conservation. So if you look at the outcome, if you, sorry, it is not a slide, but they are telling that here the outcome is comparable, and their local recurrence rates are low after neoadjuvant chemotherapy and breast conservation, even among breast conservation ineligible patients who downstage, and they are not improved in patients who downstage and choose mastectomy. So downstaging with mastectomy didn't give better outcome, and compared to that, when they have downstage and went for breast conservation, and this is the first study on advanced stage with node positive, downstaging and mastectomy, they have shown that we are getting a safe journey. So this is what I wanted to share, that I know our many oncology colleagues are there. When we discuss these things in our MDT with our surgeon colleagues, patient may think that it's a big tumor. When it's gone down, maybe we are compromising the survival. So this paper, 658 patients in MSKCC, so single center. So I think this is a robust data that we can give this reference. Our neoadjuvant chemotherapy after, I think we are safe. Any comment on that, Zakir Bhai?
This is a nice paper. I know Professor Vadia from England actually presented a paper and also wrote a paper about the neoadjuvant chemotherapy, and then downgrading the tumor and do wide local excision actually increases the local recurrence, which was refuted by everybody. But he was just questioning. He didn't actually say that he had got evidence. He was questioning it might actually increase the local recurrence rate. But that this paper is clearly showing that that is not true. And it started in 2014 to 2018. So it's almost 10 years old, or almost 8 years old data they have got. So it's a robust data. I really support that. We have been telling that. And there's a 20 years data from 2002 to 2021 that clearly showed the breast conserving surgery, which was from New England Journal of Medicine, published in 2002, clearly showed whether you do mastectomy or wide local excision and radiotherapy, they have got exactly similar local recurrence and also exactly similar survival rate. So, or maybe better actually in breast conserving surgery. Now conclusion is it's actually better. So we should follow that one.
Thank you, Zakir Bhai. So now, I mean, if there's a PCR, somebody may ask, why you have done the surgery? Is it overkill? I know we cannot achieve a PCR without doing a surgery, but this is a discussion going on that in some situation like rectum, we are now putting watch and wait, WW formula. So in breast cancer, when we are getting a PCR, can we say that is it overkill and can we avoid it?
Yes, that's a good question. So there is a study going on in America. Just started now. They started all this complete PCR group, one-sided. So they're just it's just started recruiting now. They're not doing any surgery because still we don't know. Complete PCR seeing by MRI whether this is really completed or not. When we take the tissue out, that is the time we can actually say that yes, this is complete response. But in America, what they are trying to do, they do core biopsy. Once the PCR complete radiological PCR is found, they do a couple of core biopsy. If there's negative, they're not doing any surgery at all. So let's see the result. It will take probably 5 more years or 10 more years to get the results. But this is maybe the future. So most of the breast surgeons will probably lose their job. Maybe, we don't know.
So as you said, the losing the job. So coming back to a different scenario, metastatic breast cancer, de novo. It's a big debate. We have been discussing. Indian group is saying good. Turkish say no need. Turkish say can do. Turkish study is criticized for bias. So what is your practice, Dr. Zakir, for de novo metastatic breast cancer and doing surgery?
What I'm just saying that if somebody has got already metastasis, you're talking about not only lymph node, in other areas as well, is that right?
No, distant metastasis.
Yeah, distant metastasis. I mean, UK practices, if they have got distant metastasis by doing mastectomy or wide local excision, whatever you do, you don't get very much benefit out of that. But there's a paper came out before as well, which is saying debulking of the original site tumor might improve a little bit of quality of life at the same time. They never said about overall survival. But we don't practice that in the United Kingdom unless it's actually fungating out or causing some discomfort to the patients. I know I did see that Turkish trial as well. They're saying, yes, it actually increases the better lifestyle at the same time, some survival as well. But I think we are not still practicing it. Farid, what is your comment about that?
Thank you, Jagabhai. Thank you very much. It's been almost 15 years. There are certain types of metastatic breast cancer. For example, bony metastasis, if there is one or two, not like widespread bony metastasis, but if the bone scan or PET scan showing a single bony metastasis or a one or two areas, we would still go ahead with do breast surgery. And there are published evidence, at least some 14, 15 years back, that's when we changed our practice, that these sort of scenarios, we would still do the breast cancer surgery. But if it is like, as Zakir Bhai said, majority of the cases, if there is a lung, liver metastasis, generally we do not proceed to do any surgery. That will be more of a palliative treatment. There are exception of the cases, which I would like to say that there are scenarios that we have given chemotherapy and had a complete response, radiological response with liver mets are gone. And then we found out patient had developed cancer progression on the breast, while systemically elsewhere, everything was absolutely clean. So we had further MDT and we agreed to do her breast surgery. So these are the exceptional scenarios, but otherwise what Zakir Bhai said is absolutely is the norm practice that what we do in UK. Thank you.
So Farid, I understand that you are telling that with Zakir Bhai, that is a frank metastasis de novo. Till now, we don't have enough data to support to go for upfront surgery. And we accept the Indian study as a standard study because it is a balanced trial. Because the Turkish trial, this is, there is some selection bias. So even if it is a positive trial, it is not worldwide, not accepted. So till now, the reference is used in the Tata group that they have shown there is no survival benefit. But you bring out the issue of oligomets. I understand when there is a oligomets, then yes, like many other site, breast cancer oligomets, we are treating it as a, I mean, not as a metastasis, something between metastasis and non-metastatic, where we have a better survival if we go for an aggressive approach. In the COMET trial, they have shown that after giving the neoadjuvant, if there is a good response, then we treat with radical treatment and it is giving survival benefit. So, I mean, to our colleagues listening, that the message is that as per guideline, there is no robust data in favor of metastatic, de novo metastatic cancer, breast cancer to go for surgery. And whatever the data is, sometimes there is conflicting data, but these are retrospective series. So end of the day, there is no OS benefit on. So that's why it is totally individualized. And if we plan, as Farid said, and Zakir Bhai was telling, specific cases in some situation, this may be a decision, but traditional indication for local surgery stage for breast cancer patient is palliation when it's a bleeding, ulceration, or fungation. Its impact on distant metastatic survival is controversial. Surgery asymptomatic patient do not improve survival but are burdened by morbidity. So with this, I want to take off and invite our today's schedule anchor, Dr. Mustafa, who has already joined with us. So Shuman, you can carry it from here.
Kamal bhai, just allow me to share my screen. Just off your screen. My next question is BRCA positive breast cancer, prophylactic bilateral mastectomy, whether it is the standard of care. Though we are seeing that in the United States, in last few years, there is around 3% increase in prophylactic mastectomy rate. My first question to Dr. Zakirullah Bhai is whether my screen is, Kamal bhai, can you see my screen?
Yeah, it's okay. We can see it.
So, Zakir bhai, whether you will be very happy to be informed that in Bangladesh, we are now routinely doing this BRCA test, and a certain percentage of patients, we are getting that they are BRCA positive. So, in this extent, what should be the surgical management? Zakir bhai. Zakir bhai, আমরা শুনতে পাচ্ছি না.
Or I understand.
Can you hear me? Can you hear me?
Yes, yes.
Can you hear me?
Yes, Zakir bhai, right now it's
Zakir Bhai,
okay.
please continue. Zakir Bhai, please continue. We can hear you.
Can you hear me? Okay, fine.
Yes, we
Sorry,
can
I
hear
can't see you. All of a sudden, just got. Can you hear me now?
Okay,
It's
it's
clear.
okay.
Okay, fine. Okay, now prophylactic mastectomy. It's a very interesting thing happening in the United States. The whole thing is actually shifting in America. If you see the data for last 10 years or so, the mastectomy rate was very low to start with. I think less than 21%. But now last year, what I understand, it's gone up to the 52% for this group of people. Because this is only not for the BRCA positive patients. They are actually doing for other patients as well. The reason is not only to treat the cancer treatment, but it gives quite a lot of money for the surgeon and the plastic surgeon as well. So I had a discussion with another plastic surgical colleague from America, and that is very alarmingly going high up, because the way they are actually convincing patients that, yeah, do mastectomy, you don't need to think about breast anymore, but we'll make much bigger and better breast for you. So that kind of thing is dangerous for patients. So anyway, for the BRCA patients, you have to assess the whole situation. We don't offer immediate risk-reducing mastectomy for all BRCA patients. What we do, they have to go through the counseling and to understand the meaning of this bilateral mastectomy, to understand the effect of bilateral mastectomy on psychological effect. And BRCA patients not only get breast cancer, they can have some ovarian cancer risk as well. It depends on BRCA1, BRCA2, whatever it is, or P53. So now these are the things has to be considered. And then once proper assessment is done, then they go for, they can be sometimes assessed by the psychologist as well, because we used to do for everybody psychological assessment to understand whether they understand the whole thing or not. And then we offer them bilateral nipple sparing or nipple sacrificing mastectomies for prophylactic use, or we call risk-reducing mastectomies. Yes.
So a supplement question to Zakir bhai regarding these issues. So whether mastectomy, but not, we are not talking about right now, we are not talking about a prophylactic. So regarding this breast surgery, whether you offer breast conservation in this context, if it is BRCA positive.
Oh, yes. I mean, there are some group of patients who were known to have BRCA positive gene, but they don't really want mastectomy. They want to have surveillance. So for BRCA patients, the way we normally do the surveillance, if they don't have any cancer now, we carry on doing MRI scan in the United Kingdom, along with the standard protocol of mastectomy, what we've been doing. So mastectomy, with mammogram. So the patient should have mammogram and as well as the MRI scan every yearly basis to see whether there's anything developing or not. Some patients choose to do that, but no, they don't all have to go for mastectomy. They can be observed, because we know that BRCA1 or BRCA2, 80 to 85% of the chance they get their breast cancer in their lifetime, but 10 to 15% we don't know. So that's why some patients actually decide to just go for monitoring.
Thank you, Zakir bhai. So let me ask the same question to Farid bhai, because this BRCA issue is very new here in Bangladesh, and we are really scared about this issue. So whenever I got this BRCA, we think that from oncologist point of view, we think that the bilateral mastectomy should be the preferred treatment. So what your routine practice, Farid bhai?
Thank you. Can you hear me, Shuman?
Yes.
Thank you. I totally agree with what Zakir bhai has said is the current practice in UK. In Bangladesh, because of the availability of genetic testing last 3.5 years, my experience is there are patients who, because of the strong family history, they haven't developed breast cancer, but they are BRCA mutation positive. If their family is complete, some of them get very scared and worried. And we do have a proper counseling. We follow them up at a different time so that they have adequate time to think about themselves. And then there are cases we have performed risk-reducing surgery with immediate reconstruction. Now, this is quite important to understand the setup of UK, like a developed country to Bangladesh, that we don't have robust mechanisms with high quality images, follow-up, this sort of things. And our patients groups are not as self-aware as with first world countries as well. So we usually try to do a pretty decent counseling with the patient of what they want to do. And if there are patients, we found TP53 mutation positive in quite a few patients in Bangladesh in last 3.5 years in our unit, where if there is a tumor protein 53 mutation, there is up to 100% risk of developing breast cancer. And the moment a patient, and if it's a BRCA mutation, the risk could go 50 to 85% higher of developing risk of breast cancer. The moment you do a breast risk reducing surgery and immediate reconstruction, the risk of further developing of breast cancer would be about 5%. So there is a significant reduction of risk reduction of development of breast cancer from up to 100% down to 5%. Why 5%? Because when we do a risk reducing surgery, under surface of the muscle flap, there will be a tiny amount of breast tissue left. And this is why that 5% is never 0%. Although population risk is about 12% anyway. So this is better than population risk reduction. That doesn't mean that each and everybody should have reduction surgery. As Jakir said, patient choice, there are lots of social and personal circumstances are there. And some patients in the UK, we do just follow them up with annual MRI and mammograms, where this may not be entirely feasible in Bangladesh. But again, as long as proper counseling is done, they have to decide once we give a risk assessment. And there are situations we have sought clinical psychologist opinion, even in Dhaka as well, on certain patients who were counseled for risk reducing surgery. So this is not the way what Kamal Bhai said, what is happening in USA. Certainly, it must not be seen as a business or perspective. We need to think about a patient who has got a potential developing breast cancer up to 100% within lifetime. Can you imagine what will happen to that patient once they develop breast cancer? They go through all the testing images, the stress, the treatment of surgery, chemotherapy, radiotherapy, whatever, immunotargeted therapies, whatnot. So many things they have to endure just because they have got a diagnosis of breast cancer. Comparing to that scenario, if you imagine same patient who has got a family complete, has found to have BRCA mutation, hasn't got any other high risk factors, and opts for a risk reducing surgery, her risk of developing breast cancer goes down from nearly 100% down to 5%. Can you imagine these two groups for two scenarios for same patient? So it's not like one size fits all. You have to be individualizing this treatment plan. So it is a standard of care, but there has to be some exceptions. There has to be some different ways to manage. So you cannot just offer each and everybody a risk reducing surgery, even though they have got BRCA mutations. Thank you.
So thank you for it. So let me ask you another question. As you are right now practicing here in Bangladesh, so what your routine genetic test you are offering to your patients, and what are the selection criteria? So whether you are offering to all your patients for the genetic test, or you have selected some age groups, what is your age group or selection criteria for the genetic test, and what are the usual tests for it?
Thank you. If there is a family history, strong family history of breast cancer of first degree relative below 40, then I would, even if it is one member, I would request genetic test. If there are two members below 50 or any age group more than 3 cases having breast cancer, or a combination of breast or ovarian cancer, or a family which has not only got breast cancer history, but many other different types of cancer, then I would definitely counseling about possibility of getting a genetic test done if patient can afford it. And then if the test you ask about, ideally is BRCA1 and BRCA2. On certain patients, we have done TP53, and I have to say, we have found some TP53 mutations. The samples are usually sent to Germany through the labs from Dhaka, and then they get sent to Germany, and sometimes it goes to some other countries as well. But mostly our sample goes to Germany. So they're pretty much reliable, but mostly we do BRCA1 and BRCA2. If there is we have seen male breast cancer in my chamber as well. If there is a family history of male breast cancer, then we would recommend genetic test as well, because they have got a higher tendency to develop genetic mutation related breast cancer for the female counterparts in that family. And the reality is out of total breast cancer, only 5 to 7% will have genetic mutation-related breast cancer. So it's not that huge high number. So only a few selected group of patients we would advise. Thank you.
So thank you for it. So thank you, John, for joining. So same question to you. Same question to you. In UK, what is your selection criteria for this genetic test? Whether you are prescribing all your patients or you have selected groups? Dr. John.
So we have guidance that is provided by our family history clinic, which essentially stipulates specific family tree, numbers of first-degree relatives, second-degree relatives who've had breast cancer. Generally speaking, though, if you're under 50 and you're triple negative breast cancer, then you can be referred for genetic testing. I'd say probably the thing that just takes longer than we'd like is the NHS testing does take several weeks for the results to come back. Whereas when we took part in, for instance, the Olympia trial, and we were using Myriad for genetic testing, that was much quicker. So fingers crossed, as the technology gets cheaper, we'll be able to move towards more rapid platform testing. The other thing, of course, is counselling for genetic testing. I don't know whether anyone mentioned that with respect to, it's easy to do the test, but sometimes it's counselling the patient for the implications of what that test means, particularly in regards to not just them, but their family members as well. So there's also consideration needs to be given for that.
So except this family tree, whether you consider the age, because in Bangladesh, we are getting some patients age group 25 to 35.
So under
should
50
you consider
is,
this age group for genetic testing?
Yeah, so if you're under 50, if you're under 50 in the NHS and you develop TNBC, then you'll be tested. You're eligible to be tested.
So if the patient is around 30 and she is not TNBC, suppose he is hormone positive, should you consider?
To my knowledge, and Fareed can correct me if I'm wrong, but not normally unless they have a family tree. So I can look at my guidelines and tell you in a moment.
Okay. So thank you, John, for clearing all these issues. So regarding these prophylactic mastectomy issues, if we see the ESMO guidelines, it will reflect the same words that we are discussed here, that the prophylactic mastectomy is not a standard of care. So if the BRCA positive patient is there, we can still consider for breast conservation, and definitely prophylactic mastectomy is not the answer. So right now we are going to another topics, that is the management of axilla. We are very sure that there are some controversies in this axilla. So at first, to 45, clinically note 0, what is your routine practice here in Bangladesh and in UK?
Thank you. If it is invasive cancer, we'd like to stage axilla in the form of an axillary sentinel lymph node biopsy. In our unit, we are still performing one-step nucleic acid amplification, but only for those patients who would have further axillary surgery if OSNA shows positive would be patients with post-neoadjuvant chemotherapy or more than T3 or T4 cancers, because these are not part of AMAROS or Z11 trial. So standard practices should be have a axillary sentinel lymph node biopsy. What we practice at exactly same in Dhaka as well. We don't have got that OSNA facilities in Bangladesh, so we just do axillary sentinel lymph node biopsy. If it is a DCIS for breast conserving surgery, we do not we do not do any axillary staging. Exception is if it is a widespread DCIS, that would require a mastectomy plus minus reconstruction. In that case, we will still go ahead with do axillary sentinel lymph node biopsy with a dual dye technique. Thank you.
So thank you for it. So in Bangladesh, in every center, they don't have these SLMD facilities. So surgery fast, clinically note 0. What would be your suggestion?
You have to understand the risk of doing unnecessary axillary clearance. If you are, that's why you are pointing at a clinically and ultrasonically negative axilla, I would be very reluctant to do a full axillary clearance, because based on Amorous trial, they suggested that 29, almost 30% cases of axillary clearance patient with developed lymphedema. And you have to see how difficult it is to manage a patient who has got a huge swollen arm, has compromised her day-to-day activities, won't be able to do any work, significantly compromising the quality of life. And therefore, that would be another curse we would be imposing on a patient by doing an over-treatment of a clinically ultrasonically negative axilla. You end up doing axillary clearance, and 80 to 90% time you would find out the nodes are all 18 nodes, 20 nodes, 30, 40 nodes. I've seen, they're all normal. Yesterday, I've seen a patient who was operated in Bangkok and in a very reputable hospital, and the patient had 28 nodes, all normal, and she's got a large lymphedema, swollen arm. So this sort of thing happens in other places as well. So all I'm trying to say is the SNB should be a standard of care, gold standard for clinically and ultrasonically negative axilla. Thank you.
Thank you, Farid bhai. After this NSAB B32, we know that SLNB is the standard of care. But let me ask this question to Zakir bhai. You know, in Bangladesh, though SLNB is the standard, but more than 80% center, probably the number might be higher, don't have these facilities. And how we could challenge this situation, how to adjust these issues?
Okay, first of all, we have to clear in our mind what are we going to do with this kind of axilla. Like somebody who is radiologically axilla is clear and patient has got small cancer, you're not expecting anything there, why do you do unnecessary axillary clearance? Maybe the reason is most of the surgeons are trained in such a way that they have learned how to do axillary clearance, but no other way of knowing the axilla. That is one of the reasons. So first of all, it's not patient's choice, it's doctor's choice. They need to learn. So how to handle the axilla. Now, you might come up and say that I don't have dual dye technique. Fine, you can use any dye. A single dye technique is almost 60 to 70% sensitive. The dual dye technique is 90-95% sensitive. Nothing is 100%, but still better to use single dye. Okay, second question might come, I don't have any dye. Why don't you start doing 4-node sampling, which the Scottish team did before? You don't have to go and take all the lymph nodes out. Go and open up the clavipectoral fascia, find out the true axilla, take random 4 lymph nodes out from the lower axillary area and see. That is another skill you need to learn. And I think most of the surgeons can do that one. So there's no excuse to say, because we don't have any facilities, we'll take everybody's axilla out. No, it's old, but you should not be saying that kind of thing anymore. The world has gone far away. So please, for all the surgeons who are listening now, or even the oncologists, advise them if it is axilla is clear, axilla is nothing radiologically, take sentinel lymph node. If you don't have facilities, do 4-node sample. That is much better way of assessing axilla.
So thank you, Zakir bhai, for your very bold statement. I think all of us should follow this statement, because all we have, we should properly utilize our resource for the benefit of our patients. So let's jump to our second question. If SLN becomes positive, 1 or 2 sentinel lymph nodes positive comes with positive, then what should be your practice for it at first?
Thank you.
SLNB comes
The
out
standard
1 or
of
2 lymph nodes
practice
positive.
we would discuss in MDT. The standard of practice, which would be patient will be counseled preoperatively as well. Even if it is positive, we would not do any axillary clearance. The exception would be if it's a neoadjuvant chemotherapy patient. If there is 1 positive node, or even if there's a micromass, then we would do axillary clearance. That is the current practice happening in UK in our unit as well, and many centers, if not all. But generally speaking, if a patient has got just breast cancer surgery and you do a sentinel biopsy, 1 or 2 positive nodes, based on Amorous trial and few other trials as well, you could tell more. It's obvious that simply radiotherapy to axilla would have a better outcome, as it would be almost identical outcome. But as far as risk of complications, axillary clearance have got 1 in 3 patients who develop lymphedema, whereas Amorous trial did show that only 14% patient would have lymphedema if they get axillary radiotherapy. So radiotherapy can take care of positive nodes if there is 1 or 2 sentinel nodes found to be positive in axilla during sentinel biopsy, not necessarily requiring to do axillary clearance apart from exceptions. Thank you.
Kamal bhai, please.
So I have a question to John. John, normally or mastectomy, we avoid axilla when axillary dissection is done. So is there any situation axillary dissection is done, but still you would like to treat the axilla? I mean, because this is a confusing area. People think the axillary dissection is done, so I avoid axilla, I treat supraclav and the chest wall or the whole breast, plus minus I am known. Because axillary dissection is done, so I don't treat axilla. But is it a rule of thumb, or there are some situations where we need to, even after axillary dissection or SNB, we need to treat the axilla? Can you please clear it? Because this is an area, a gray zone. I think in our country, things are happening.
So I'd say, Kamal, I do the same as you, unless there's specific axilla information shared at the time of MDT or histology discussion. So a good example might be if the lymph nodes in the axilla were matted and they've had difficulty dissecting them, for instance, from the axillary vessels. So if the surgeons feel that there's a likelihood that there's macroscopic disease they couldn't resect, then I will include that in my treatment volume. The thing I sometimes wonder about is when they've had axillary dissection and there's comment on extracapsular spread. So does that mean, so if we think about lung cancer these days, when they resect lymph nodes from the mediastinum and there's extracapsular disease, I will consider that for mediastinal radiotherapy, even though the evidence suggests that there's no role for post-operative radiotherapy to mediastinal nodes. But it doesn't seem as though that flows into breast cancer. So the way that I envisage it is that where you've dissected the lymph nodes and they're surrounded by axillary fat and connective tissue, that extracapsular disease is contained within that en-bloc resection. And I have to say, I don't remember in recent times the last time I saw a axillary recurrence in an axillary dissection patient who didn't have radiotherapy, if that makes sense. It's much more likely they'll get local disease recurrence, for instance, in their supraclavicular fossa or in IMC nodes, not the axilla, in my experience.
So Kamal bhai, it's okay.
Yes, proceed. Yeah, okay. It's okay.
So my question to Zakir bhai. So as per this ECOSOC Z00, if sentinel lymph nodes 1 or 2, you can avoid. So what will happen when Sesselmin is node is 3 lymph nodes comes positive? What would be our practice?
That's a very interesting thing. That's a very interesting question. Because I think if you follow the Z11 study, they're talking about 1, 2 lymph nodes, up to 2 lymph nodes. But if you go up to 3 lymph nodes, it's a controversial thing is coming out. Z11 is also not actually said that you have to do radiotherapy for 3 or more lymph nodes. So normally up to 1 to 2 lymph nodes, I think most of the centers, they can actually give some radiotherapy to the breast and that will cover the lower zone lymph nodes. But when 3 comes, obviously axillary clearance is the standard procedure we normally use here. However, I must say that I completely agree with Farid, but we are still not every center in the United Kingdom actually following that Z11 protocol. Some of the centers still, if 1 lymph node is positive, they're still doing axillary clearance because they're waiting for the trial, which is the British version of the Z11 trial, to see what the result shows, and then they will probably adopt that policy of not going back. But in our hospital at Barts, we are still doing axillary clearance, which is probably a bit backdated, but we are just still waiting for the trial results. Okay.
So let me ask this question to Dr. John. John, right now we have Z11 and Amorous trial. We have 10 years data from the MRS trial, and we have seen that these are shown that equal outcome with radiation therapy without more doing axillary dissection. But the MRS trial shows that the second malignancy is quite high with the radiation therapy group. So what your comment regarding these issues, Dr. John?
Apologies, I missed that question. Sorry, what was the question?
The MRS trial, in MRS trial, they have shown that the equal outcome with SLNB followed by radiation therapy. But
Yes.
the second malignancy is quite high. That is quite around 25 or 30% high in the second malignancy, particularly in the breast side. So what your comment? Should we consider these issues regarding this, regarding our practice?
Yeah, so I'd say that in the MDT, we have I'd say we do have a kind of equipoise when it comes to offering radiotherapy versus surgery for clearance. So yeah, so I'd say but it's interesting, the data, there does seem to be, I know we're looking at this now, axillary recurrence from radiotherapy. I do think that surgery seems to reduce the risk of local recurrence versus radiotherapy, you know, so there's times if you've got heavy, you know, 4 out of 4, that we do counsel the patient towards surgery, and often patients, if they're well read, will come and will feel a pull towards surgery rather than axillary radiotherapy, in my experience.
So thank you. So if I to summarize this axillary management, so we have already discussed these issues. So regarding, this is a synopsis for the axillary management. So if it is clinically N0, SLNB is the practice, and if it is more than 2 nodes positive comes with SLNB, we should do the axillary lymph node dissection. This is the guidelines. So now talk to about the neoadjuvant chemo, clinically initially node positive, and now after chemotherapy it comes to N0. So Farid bhai, you are talking about these issues. Now can you formally discuss these issues? Initially N0, N positive, after chemotherapy N0.
Thank you. What I would like to say that in current practice in my unit in UK, as well as in Bangladesh where we practice, if post-neoadjuvant chemotherapy who had negative axilla, clinically and ultrasonically, we would do SNB and frozen section of axilla node. If the node is positive, we do clearance. In the UK, we do SNB, OSNA. If OSNA is positive, even if it is micromets, we would still go ahead and do axillary clearance. That is the post-neoadjuvant chemotherapy patient with no negative clinical and ultrasonic findings. But if patient had positive nodes on FNAC or KBAC, pre-neoadjuvant chemo, and patient undergoes the chemotherapy, then many centers in UK, we are still progressing to do axillary clearance upfront. But there are a lot of centers gradually doing clipping of the nodes, which is the positive nodes get clipped, and we just remove that node post neoadjuvant chemosurgery. And if the clipping node is normal, we don't do any axillary clearance. So that is the newer practice, which is ongoing, gradually getting more and more popular in UK. But I have to say, we haven't got that far in Bangladesh as yet, but we have future plans, and hopefully we should be able to do it. And on that note, may I seek permission from all of you, if I'm allowed to, if I'm permitted to leave. I have to go for important MDT and see a patient. If I'm allowed to leave.
Absolutely fine from my side.
Okay, okay, Farid. Thank you very much for joining.
Thank you for joining.
Thank you.
Hi, Farid.
Shon bhai, you need to unmute.
Thank you, Arman. So Zakir bhai, regarding this axillary management after neoadjuvant chemotherapy, the paper says, because we are not surgeons, we don't have practical experience, the paper says that findings the nodes is quite difficult because the fibrosis there. So what should be the practice in after neoadjuvant therapy?
Okay, so just to clarify the thing, it depends on how many lymph nodes. Please, watch carefully what I'm saying. Yes, the first thing is, if somebody has got multiple lymph node positive before you start chemotherapy, then no question what is going to happen after neoadjuvant chemotherapy. The patient needs exudate clearance. Finish. So that's the treatment. If some patient has got only one lymph node or two lymph nodes positive, then the two choices. Normally in the United Kingdom, what we do, we mark them, called targeted exudate dissection. So we put them with a small marker within this lymph nodes, and then have chemotherapy. And after the chemotherapy, if radiologically it shows that everything just vanished, then we go and do sentinel lymph node biopsy along with taking these two lymph nodes out. They could be the same sentinel lymph node, or they could be something different than the sentinel lymph node. Always remember that the lymph node which have been picked up before surgery is not always, before chemotherapy, is not always the sentinel lymph node. That's why you do sentinel lymph node biopsy plus taking these two lymph nodes out. If these two lymph nodes come back as completely negative, including sentinel lymph node, then you don't need to go back and do axillary surgery or axillary clearance. If any one of these lymph nodes are showing any micrometastasis, then they have to go back and have axillary clearance. Am I clear?
Yes, Zakir Bhai. What you have mentioned, that is clearly stated here in ESMO 2019 guidelines. You could see that after neoadjuvant chemotherapy, we could offer SLNB only for this group, that is clinically N1 at onset, no matted nodes. And biologically, those who are prone to get higher PCR rates, the TNBC HER2 positive cancers, and we have to use these dual tracers, and at least 3 SLNB lymph nodes should be localized. Okay. And as you said, the targeted axillary dissection is promising. That is another story. So we should think regarding this SLNB after this neoadjuvant chemotherapy. My question to Dr. Zakir Bhai, we have a perception that after the neoadjuvant chemotherapy, breast conservation surgery is not the ideal choice. So you should give a lectures regarding this myth breaking.
No, I think, please remember, whenever we take decision in our MDT meeting, we all consider what would be the treatment option after the chemotherapy. So that management actually decided beforehand. So first of all, you need to know if somebody has got multifocal cancer in the breast and it's a big cancer, even if it responds beautifully, but breast size is so small, you decided from the very outset that no, this is not a breast conservation, there's no breast conservation surgery will be done here. So that is a completely different decision. That is before chemotherapy. But if somebody is borderline, when we think that yes, if there's a good complete response of the tumor is going to happen after chemotherapy, then we'll do breast conserving surgery. The treatment option is that put a marker clip, sometimes maybe both ends of the tumor or sometimes at the center of the tumor. So mark that before you start chemotherapy. Then start chemotherapy. If chemotherapy shows complete response, radiological response, you just go and pick up the marker clips with the wire guidance or radio frequency guidance, that just take that clip out with maybe a centimeter surrounding margin. If that comes back as clear, you don't need to do mastectomy or do any other surgery at all. But if that comes back as some patchy necrosis of tumor and still some tumor is left behind, then you have to go back and clear the margin. If that margin comes back as again positive, then there's no other option but to go back to the same plan of doing mastectomy. Is that clear?
Yes. So Zakir Bhai, so neoadjuvant chemotherapy is not a contraindication for breast conservation surgery.
Not at all. Not at all.
So thank you. So you are the only surgeon right now. We are right now here in Bangladesh. We're hearing a lot regarding this oncoplastic breast surgery. But as an oncologist, we really don't know what really does it mean. So can you please give us an idea regarding this oncoplastic surgery?
Okay, just a brief idea. There's two words attached here. One is onco, another one is plastic. Onco means the surgeon who is doing this oncoplastic surgery has to have full understanding of oncological side of the cancer. That is much more important because that's coming first. The surgeon should not do surgery to make the breast beautiful or reshape the breast. So that is not the main idea. Main idea is make sure the oncological clear margin is there before you do any surgery. And the plastic bit is coming up here because we are remolding or remodeling the breast so that it looks like a breast, not like lumpectomy the way you used to do, chop out a part of the breast and it looks awful. It's better not to have lumpectomy for the patient. I mean, mastectomy looks much better than lumpectomy in that situation. So oncoplastic surgeons are doing assess the whole situation, understand where the cancer is, make sure the cancer is getting cleared first, and then with plastic surgical technique, you just reshape the breast in such a way that after the operation, patient will feel like that not much harm has been done or deformity has been done to the breast. So for example, I can give you, if somebody is doing local glandular tissue displacement and then replacement by the local glandular tissue, that's less than 20% of the breast tissue has been taken out, then you can do type 1 or basically technique 1 type of oncoplastic surgery, just local glanduloplasty. But if somebody needs to get more than 30, 40 or 50, up to 50% of the breast tissue will be taken out, then we have to do some sort of which called level 2 type of oncoplastic surgery. You need to have a training in plastic surgery to make some flap or to raise some flaps or do mastectomy with immediate reconstructions with implants or DF flap, that kind of things. In Bangladesh perspective, I can tell you, if you do type 1, or I would say the oncoplastic 1 type, at least 20% of the glandular tissue take out and replaced by local volume and the replacement of this volume, that is the best option to start with first. And that's why we are saying that don't go more than 20%. If you go more than 20%, you need to have some training with the plastic surgeons, and I'm sure your plastic surgical colleague will help you. But below 20%, you don't need any plastic surgical training. What you need is the idea or the concept of understanding how this local flap can be mobilized and replace that volume of the breast tissue has been taken out. That is called oncoplastic. But main thing is oncology first, then plastic second.
So what you have got that any kind of excision followed by reconstruction, any kind of reconstruction, if we combine it together, that is the oncoplastic surgery, probably.
Absolutely.
So thank you, Zakir Bhai. Next, my question to Dr. John Conivier. The question is from the chat box, and this is a very common question. The core biopsy.
You were frozen for time being. Say again.
Yeah, am I audible right now?
Now
Okay.
it's
I
okay.
can hear you. Yeah, far away.
Okay. John, can you hear me?
Yes.
Okay. The question is before the neoadjuvant chemotherapy, core biopsy, immunohistochemistry, ER/PR, or HER2 positive, anything that comes out. After the neoadjuvant chemotherapy, when we are going with the post-operative specimen, again the immunohistochemistry, there we found some discordance. And our histopathology says, suppose initially it was hormone positive, and after chemotherapy, it becomes chemotherapy negative. Whether it is possible, and if it is possible, what is the percentage, Dr. John?
So personally, I haven't seen that happen. So that level of discordance, I would ask our histopathology team to retest both samples. So in the course of 4 months or 4 or 5 months of neoadjuvant treatment, I haven't seen something myself go from HER2 positive to negative or ER positive to negative. You know, I'd also look back to see if we missed something on the original imaging, you know, that it was multifocal and there possibly was another lesion there that got missed, rather than it being the same tumor cells that have become receptor, you know, their receptors have changed. And so over the course of over a longer natural history of disease treatment, so for instance, in the non-early breast cancer setting, there I would say we do see receptor changes where patients have been on long-term systemic therapy. So transformation from ER positive to triple negative, I'd say that happens in my clinical experience in about 20% of patients, so not a huge number. And I always still consider treating the most aggressive variety of the receptor status. Yeah. So if they do become triple negative, then I'll reevaluate them for triple negative disease. But that's not normally in an early breast cancer setting, in my experience. Kamal, what's
So
your
what we
feeling
can
on that?
say,
Have you seen that happen much? Or should we?
Kamal bhai,
So John,
Kamal
I have seen this, but I am totally agreeing with you that the data is for recurrent cases after a certain period. So 10% there is the data paper says 10% chance. So that's why when there is a metastasis, there is always a recommendation of repeating the status. But what Shumon is telling in our country, unfortunately, we had, not very frequent, but quite a few cases. Even I have found that pre-op core biopsy and final histopathology, receptor status change or the HER2 status change. And then two question comes, whether it has changed because somebody tried to convince that due to chemotherapy, it has changed, which is not a scientific explanation. Then we need to understand which one is correct, whether the previous one is correct or the final one is correct. So what we need to do, it is challenging. We need to take both the specimen, go for the third one. And this is a real challenge. And one of my colleagues was telling that she don't treat a HER2 positive without a FISH test. Why? Because she has burnt her finger with IHC because she found that IHC3 positive, but finally it came out negative. So even it is not a science, but it is her experience driven that when she go for an anti-HER2 therapy, she want to do a FISH and I cannot blame because we are taking a decision, expenditure. So Shuman, the answer is scientifically, there is no valid reason of thinking that during the 6 months of chemotherapy, receptor status changed and the HER2 has changed. But in recurrent setup, there is chance, and that's why the recommendation is we should repeat the receptor status.
so Zakir bhai, any comment?
That's true. Actually, I think we need to understand the histological standard in some places in Bangladesh. You know that, and also we need to understand the specimen, the way it's actually going to the histopathologist. I did say this thing several times in the past because now everybody is learning that tissue should go fresh rather than lying down for 8 hours or 10 hours. So that can alter the whole scenario of your this hormonal status. ERPR rate is much higher. We just said that in Bangladesh, and triple negative is much more higher in Bangladesh compared to the rest of the world. Maybe that is true. I'm not actually ignoring that. But of course, the chemical and agent, other things are used as well. So I think I haven't seen any. We have seen field change or this kind of changes after prolonged treatment and maybe a few years down the line. About 10% of the patients can have this kind of field change. But I haven't seen any immediate change. But we don't, to make it much more interesting, we never do actually check the ERPR status after the specimen is out. We do only core biopsy. If core biopsy shows ER positive and HER2 positive, then we stick to that. We don't check again.
So better not to recheck.
I think so.
So what I have got from all your discussions, that any of the two reports is wrong. Whatever our pathologist colleagues trying to understand, make us understand, any of the two reports is wrong. That is the usual scenario. So that's all from me, Kamal bhai, and now I am handing over to you for a few words.
Thank you, Shuman. It was a great.
Kamal bhai,
Salma.
Can you ask me? Will you allow me to ask a question to Zakir bhai?
Please.
Okay, so is it some kind of heterogeneous, the immunohistochemistry? Can it be something else at different areas of tumor, or can it be different in the breast or in the axilla, metastatic nodes? Can it be heterogeneous?
You are talking about that your
Immunohistochemistry.
immunohistochemistry in the breast is
Yes.
showing that it's ER positive and HER2 negative, but the lymph node is showing that it's ER negative and HER2 negative or something like that. Is that right?
Yeah.
That's what you're doing.
Yeah.
Okay, that's a good question. It can happen. I'm not saying that if they have got multifocal cancer, it's not true for the same one single cancer. Because most of the times, if single cancer is actually isolated, we don't do immunological status of the lymph node.
Yeah.
We only do immunological status of the lymph node when we find multifocal cancer. One is ER positive, another one is ER negative or triple negative. It happened. And then we do whether there's any lymph node involvement to check with what is the immunological status of immunohistochemistry of the lymph node. But normally we don't see any difference at all. If it is a singular cancer with ER positive and HER2 positive, the lymph node should be ER positive and HER2 positive.
And HER2 positive, yeah. Another question is that, can it change after the neoadjuvant therapy?
Not
It's actually
immediately after the. That's a good question, Salma. That's what we were discussing a few minutes ago.
Yeah.
We haven't seen immediately after chemotherapy or any sort of treatment of these patients, neoadjuvant chemotherapy, that this will get changed. No, field change happens maybe a prolonged treatment, and then after 5 or 10 years down the line, we have seen some changes, but not immediately. I haven't seen, and John hasn't seen either. John also said he hasn't seen.
Because I have seen, that's why I am asking the questions.
Yes,
I think that's after the neoadjuvant chemotherapy, after the surgery, the immunohistochemistry changed. That's a great challenge, I think, for the planning the treatment of this patient.
Salma, you're absolutely right. That's why we are discussing this. Kamal was saying that it happened several places. So stick to one consultant pathologist or one department, whatever. And if you are really worried about the immunohistochemistry in the first place, then do the second one. But if you're completely happy with your core biopsy, there's no point of doing another immunohistochemistry for your tissue.
I had another question.
Yes,
that's regarding the axillary lymph node. The FNSC, is it in some cases, I find that the clinically node is palpable, and I'm sure clinically it is positive node, but the FNSC came as negative. So I have started doing core biopsy in the axillary lymph nodes. Is it better to do core biopsy than FNSC? Because many of the cases, my radiologist is doing the ultrasound guided FNSC from the axilla, but it is coming negative. It's a great dilemma, actually.
Salma, it's a fantastic idea, because if there's any doubt, always do core biopsy. Even here, when we actually do FNSC of the lymph node, if it comes back as LNC2, which is benign, we don't believe that, or radiologist is saying that radiologically it's more than 2.5 millimeter or more than that, the cortical thickness is more, we always do core biopsy. So if you've got the facilities of doing core biopsy, in the first place, instead of doing FNSC, you can do core biopsy.
Yeah, I have started that because with FNSC, I had a lot of dilemmas.
Yeah, fine. Do core biopsy is much better. You can see everything properly. And FNSC is very difficult to read as well, unless you've got a very good cytologist. It's very difficult to interpret as well. So I would go for core biopsy if you have got the facilities. Absolutely right.
Thank you. Thank you, Zakir Bhai.
Thank you.
So, John, to you and Zakir Bhai, supplementary question to Salma. So Salma is confident about the node positivity. Ultrasonography is telling thickened cortex. We have done FNSC, adequate sample negative. Core biopsy not possible. As a clinician, I want to trust my surgeon colleagues' finger and also my radiology and even it is negative, we want to treat it as positive. So John, will you go for taking out the nodes and confirming it is a positive, or you will treat this case as a node positive? Every reason to believe it is a clinically, but somehow we cannot prove it pathologically.
It's interesting. We discussed a case recently, didn't we, where the enlarged lymph nodes turned out to be TB. And so, there's other causes of enlarged lymph nodes, particularly these days with COVID vaccinations. So I'd probably want to be certain and see some histological proof that there was node positive with tumor cells, rather than assuming, clinically they're palpable, etc. That would be my feeling.
Thank you, John. So I think we can end up, because this discussion will never end, never ending. So we have brought from one session to two sessions, and still we see, and we are happy to see that the people like Salma is raising the question, if the juniors are raising the question, and it was quite interesting to see the interaction. And we tried to make the session interactive. That's why we made 2 days from 1 day. And we are very happy to get the support from our overseas colleague, John, Dr. Zakir, and also Farid. So I want to thank all of you, because today is the last session of our breast cancer session. Very soon we will start our lung cancer session, we'll let you know. And we are thinking of doing some structured program on certified course that will inform you later on. So today we want to finish because already we are 20 minutes over from the scheduled time. I'm sure our president didn't like it, because he wants us to start on time and finish on time. So sir, without making any more delay, would you please make the conclusion remark? And before that, can you please, Tania, show the poll winner of last week? So Dr. Ali Nafisa, Dr. Mahmudul Hassan, and Sardar Boniullah Ahmed. So we can see that surgeons were quite keen in not responding, also participating in the poll. Congratulations to all the poll winners. Our volunteer will send the gift to you. So sir, Professor Heiser, can you please?
Thank you so much. Very nice discussion today. Very nicely discussed, and also participants very energetic and learn many things from this. Thank you all very much. We will meet again in future. Allah Hafiz, everybody. Over to you, Kamal.
So thank you very much. So goodbye, everybody. And don't worry, we will have some more sessions on breast, maybe not this format, but different format. We'll have John with us. We'll have Dr. Zakir with us. Oncology Club is busy in developing manpower in the field of cancer care. And we are happy and fortunate to have you people with us. And we are confident that this journey will continue with your support and the participation of all the participants. Thank you very much. Goodbye, everybody. Stay safe.